Hello and good morning, everyone. My name is Camilo Gonzalez Velasquez, and I'd like to welcome you to this Friday's TIRO by MD's webinar. Thank you for joining us today for what promises to be a highly educational and inspiring session. Today, we're honored to welcome Dr. Teresa Ramone, who will be presenting her group's recent publication on the use of molecular tests as predictors of prognosis and progression in patients with low-risk papillary thyroid carcinoma undergoing active surveillance. I'll start us off by introducing our esteemed guest today. Dr. Teresa Ramone earned her degree in biological sciences in the University of Pisa in Italy in 2016 and is completing her master's in medical genetics. Since 2017, she's been part of the Department of Clinical and Experimental Medicine at the University of Pisa under Professor Rosella Elisei. Her research has focused on mutational profiles in thyroid carcinoma, expanding to include gene alterations beyond red mutations in medullary thyroid carcinoma, as well as studies in papillary and anaplastic thyroid cancers. Her work has greatly contributed in advancing molecular biology techniques and improving cancer diagnostics and patient care. Joining her is our expert discussant, Dr. Alan Ho, Professor of Surgery at Cedars-Sinai Medical Center in Los Angeles, where he serves as Director of Head and Neck Cancer Program and Co-Director of the Thyroid Cancer Program. Dr. Ho's research is internationally recognized, particularly in thyroid cancer risk stratification, cancer proteomics, and mechanisms underlying lymph node metastases. We look forward for his expert insights during today's session. Before I hand off the session to Dr. Ramone, I'd like to remind our audience to tune into the Voices of Wisdom podcast, where we share clinical pearls and relevant topics by thyroid cancer specialists for thyroid cancer specialists. Our most recent episode features Dr. Carrie Cunningham as guest, discussing the financial toxicity in thyroid cancer patients, with our fabulous host, Dr. Daniel Hartle, guiding the conversation. The podcast is available in all major platforms, including Spotify, Apple Podcasts, and YouTube. So with that, I'll now hand over the session to Dr. Ramone for a presentation.
Good morning, dear colleagues. Before I begin my presentation, I'd like to thank you for this kind presentation, and I was also to thank you for inviting me for this journal club and this meeting. It's a real pleasure for me to discuss with you the data about our recent publication, Molecular Profiling of Low-Risk Papillary Thyroid Cancer, Carcinoma, mPTC, on Active Surveillance. I have no potential conflict of interest to report. This is the agenda for today. I will present you our study on papillary and mPTC of patients undergoing active surveillance. I will introduce you the background of this topic from active surveillance program to genetic features of PTC tumorigenesis. And then I will discuss with you the methodology that we have used to characterize these patients and the results that we have obtained, in particular the molecular findings and the correlation with the clinical outcome. Finally, the conclusions that we have drawn with this paper. As you know, PTC is a heterogeneous group of thyroid tumors deriving from follicular cells and with different macroscopic and microscopic features, and also with different clinical outcome. According to the WHO classification system, thyroid microcarcinoma is defined as a papillary thyroid cancer that measures 1 centimeter or less in its maximal diameter. Although this tumor is usually indolent, it is most common form of thyroid cancers that we diagnose today, probably due to the increase of use of imaging techniques, but also for the screening program adopted in the different institutes. Therefore, its clinical management has become a matter of great importance, as the overtreatment of this type of cancers may expose patients to unnecessary risks, and while undertreatment may allow the disease to progress in a minority of cases. So it is very important to understand the different growth dynamics of cancers. As you can see in this figure, it illustrates the different growth dynamics of cancers. In particular, the red line indicates a fast-growing cancer that rapidly reaches a size that causes symptoms in patients, while yellow line indicates slow-growing cancer. Usually, we detect these cancers with a screening program, and they didn't give symptoms in patients. Very slow and non-progressive cancers have a very slow growing rate. We can detect these cancers through screening, and probably they never grow to cause clinical problems. Once detected, this type of cancers, non-progressive as very slow cancers, lead to the interventions by clinical practice. So this figure indicates the balance between the early detection of cancer against the risks of overdiagnosis and overtreatment, in particular for low-risk papillary thyroid carcinoma. For this reason, the concept of active surveillance has been introduced for many types of cancers. According to the National Cancer Institute definition, active surveillance is regarding to watch patient's condition, but not giving any treatment unless there are changes in the test results that show the condition is getting worse. Active surveillance may be used to avoid treatment such as surgery, and during active surveillance, certain exams and tests such as blood test or imaging test can be done during this protocol. For this reason, also low-risk papillary thyroid cancers have been introduced active surveillance. Active surveillance for low-risk papillary thyroid cancers was first introduced in 1993 at Kuma Hospital in Japan, and after 2 years it was adopted also by Cancer Institute Hospital. This pioneering experience laid to the foundation of the concept of active surveillance as management options for low-risk papillary thyroid cancers. And during the years, many centers in the world, including our center in Pisa in 2014, adopted the active surveillance in their clinical practice. In parallel with these studies, also different scientific societies introduced active surveillance in their guidelines. As a result of these studies, active surveillance emerged as feasible and safe for low-risk mPTC, also because only a minority of enrolled patients, between 3 and 6% of the cases, required to be surgically treated because of tumor progression. This is the clinical characteristics of low-risk papillary thyroid cancers, that we know they are indolent tumors, but we know that they are cancers. And the cancer is considered as a genetic disease, so we know that genetic markers are involved in the tumoral transformation. In particular, the genetic landscape of PTC has been well characterized in these years, and we know that the most involved gene in PTC tumorigenesis is BRAF, RAS, and gene fusions, and that they are mutually exclusive events. BRAF, RAS, and gene fusions are driver molecular markers, so they lead to the tumoral transformation of follicular cells. But we know that other alterations, secondary or acquired alterations such as TERT promoter and TP53 alterations, mutation, single nucleotide variant of these genes, are involved in the progression of disease. So it is very important to fully characterize the molecular profile of these tumors, also to predict to understand the behavior of these cancers and also the clinical in the patients. But during active surveillance, how we can identify those rare patients who will progress during active surveillance. We asked them as this important question, and the aim of this study was to find a molecular signature of cases that showed the disease progression during active surveillance, which allow the early identification of those rare patients who will show progression. In our institute in 2014, in our center started a prospective observational study of active surveillance. We enrolled adult patients with a single thyroid nodule smaller than 13 millimeters, with a final needle aspiration cytology positive for type 4 or type 5 result according Italian consensus cytology, and without evidence of metastatic lymph nodes. Patients with calcitonin levels basal or stimulated, suggesting a medullary thyroid neoplasia, were excluded from this protocol. Patients on active surveillance underwent regular evaluation at our institute. They performed neck ultrasound every 6 months for the first 2 years, then every 12 months, and also blood test. The disease progression was defined as an increase in nodule size, particularly an increase of 3 millimeters on 3 diameters, or 13 millimeters in one of the diameter, confirmed by 2 consecutive evaluation, or by the appearance of metastatic lymph node lesions, confirmed by fine needle aspiration and thyroglobulin level. The other patients that didn't show these features were considered stable disease, and they continued their follow-up and the protocol of active surveillance. We selected 95 patients on active surveillance were selected for this study. Patients provided an informed consent for the use of a biological sample extracted by routine needle aspiration for mPTC genetic analysis. In particular, the needle used for this analysis was washed in 2 different conservative buffers, and they were stored until the nucleic acid extraction with 2 different commercial kits. The DNA and RNA extracted from these materials were used to the molecular analysis. This is the workflow molecular analysis that we have used to characterize the molecular profile of our samples. We know that genetic single nucleotide variant as BRAF V600E, for example, and gene fusion are mutually exclusive. So we started with the first step of analysis, how to regard the single nucleotide variant in hotspot mutation in driver gene involved in mPTC tumorigenesis. In particular, we used the next generation sequencing approach. We used the target custom panel designed in our lab that included the most common genes involved in PTC tumorigenesis, and positive cases were considered when a driver mutation was identified, while negative cases were studied for gene fusion. In this case, we used the RNA for gene fusion analysis. Also, in this case, we used the NGS approach and the target custom panel designed with 40 specific gene fusions. And positive cases were considered when gene fusion was identified, while negative cases were considered at this point negative for alteration that we have included in these panels. After we analyzed also, for its important role in PTC, the TERT promoter hotspot mutation using a droplet digital PCR. 95 patients were selected, and 60 patients, according to the protocol criteria, decided to opt for the surgery for personal reasons. So they were considered patients dropout, while 89 patients remained on active surveillance. 8 patients showed the event of progression. In particular, 2 patients showed an increase in nodule size, while 6 patients showed lymph node metastasis. 81 patients remained on active surveillance because they were considered in stable disease without evidence of progression. These 8 patients that showed immense progression were submitted to the surgery, and histological analysis confirmed the diagnosis of PTC. This is an oncoprint that shows NGS molecular analysis, NGS molecular profile of our 95 patients. As you can see, BRAF V600E was the most frequent alteration with a prevalence of 66% in our cases. 3 cases showed RAS mutation, in particular 2 NRAS mutation and 1 KRAS mutation, and 3 patients resulted positive for gene fusion in RET and TRAC1 and ALK genes. As you can see, we found also other mutation in other genes that they were germline mutation that we will discuss after in another slide. Our study confirms the higher prevalence of the BRAF V600E mutation in mPTC. A similar prevalence of this mutation was reported also in retrospective series of mPTC. In fact, several studies were performed, have investigated the mutational profile of mPTC in post-surgical samples. And in this study, the prevalence of BRAF mutation was in agreement with our result. The prevalence of RAS mutation was higher than in retrospective studies in mPTC, but lower than reported in TCGA. We know that RAS mutation prevalence is higher in bigger thyroid tumors, so this result in our series was expected. TERT promoter mutation, the co-occurrence of BRAF and TERT promoter mutation is associated with a poor clinical behavior. In our cases, none of the investigated cases showed a TERT promoter mutation, and similar results have been reported also in retrospective studies on mPTC. Then we correlate the molecular markers and molecular genetic profile that we have found also with the outcome of the clinical outcome, in particular between the group of stable and progressive patients, and the specific molecular profile of this group, stable and progressive mPTC, did not show any statistical difference in the prevalence of genetic alterations. We observed that 5 of the cases of BRAF V600E positive cases that showed progression disease, 4 of them they showed lymph node metastasis, while 1 case that was NRAS positive that showed the progression was detected for an increase in nodule size. This is an observation that we have done, but without any statistic test, because the low number of cases that showed progression. Although a good consensus on the prevalence of BRAF V600E mutation in different series of mPTC have been established, conflict results have been obtained about BRAF V600E prognostic role. This is a waterfall graph where each bar indicates the patients, and the color indicates the genetic analysis, the genetic result. As you can see, we have several patients BRAF positive that they are on active surveillance after different months. In fact, we concluded that BRAF V600E mutation didn't correlate with the tumoral progression, and our study demonstrated that molecular profile of mPTC does not help in identifying those patients that will progress during active surveillance. In fact, according to our result, BRAF positive result is not an exclusion criteria for patients to enter in active surveillance protocol. In the oncoprint slide, I showed you that different germline mutation were identified during the genetic profiling of these cases. When we observed, thanks to NGS approach, we can detect also allele frequency. And when we detect a higher allele frequency in some different gene, we suspect to a germline mutation that we confirm on blood, on DNA extracted by blood. And we have done this, and according American genetic guidelines, germline mutation should be defined and classified in 5 different classes of pathogenicity, from benign, likely benign, to pathogenic. And we classified this mutation according to these guidelines and supported by ClinVar database. We obtained that a lot of these germline mutations were considered likely benign or variant of uncertain significance, sometimes in association with BRAF somatic mutation as the BRAF V600E alteration, but no difference were found in distribution of these germline variants between stable and progressive mTC groups. We observed that 2 variants affecting CHEK2 gene were classified according to ClinVar database as likely pathogenic and pathogenic. In the first case, the mutation indicated with the red color, it was a likely pathogenic variant, and in both of these cases, it was associated with a somatic driver mutation in BRAF V600E alteration, while the second one, considered likely pathogenic or pathogenic, was not associated with any somatic driver mutation. CHEK2 gene is involved in DNA damage response. It was associated also with an increased risk of some cancers, but further investigation need to elucidate its role on mPTC tumorigenesis. In conclusions, our study confirms the higher prevalence of BRAF V600E mutation in mPTC. However, its findings seems not to correlate with tumor progression. Although the number of cases is very limited, we hypothesize a different biological behavior of progression in mPTC according to the oncogenic mutation, with a higher likelihood to develop metastatic lymph nodes in BRAF V600E positive cases and a higher probability of diameter growth for RAS positive cases. The absence of TERT mutation in our series, composed of small tumors, reinforce the concept that TERT mutations intervene only in advanced stages of tumor transformation or cases with a lower differentiation degree. Our study demonstrated also that the molecular profile of mPTC does not help in identifying those patients that will progress during active surveillance program, and that the molecular profile should not interfere with the choice to enroll patients in an active surveillance program. To better explain the different biological behaviors of progressive and non-progressive mPTC, we probably should consider alternative mechanisms such as a differential expression profile, epigenetic alteration, and immunoregulatory mechanisms. I'd like to thank my cancer research group and the coordinator, Professor Elisei, and the laboratory team, in particular Dr. Raffaele Ciampi, that supported NGS analysis and the interpretation of the variants. The clinicians team, in particular Dr. Arianna Ghirri, that shared with me the work behind this publication, and Dr. Leonora Molinaro, that together with Professor Elisei, they started the active surveillance program in our center in 2014 in Pisa, and they followed patients during all these years. And finally, I want to thank you for your attention.
Dr. Ramone, thank you for your work. I want to congratulate you for your presentation and the work behind this, from the initial cohort to what you have just presented. We're gonna jump right over to Dr. Ho's discussion, and we'll come back to the Q&A at the end. I do want to encourage the audience, if they do have any questions, please send them through the Q&A function so we can address them at the end of the presentation.
Great. First of all, Teresa, congratulations. It's a Herculean work to get all those samples, process them, and see it to completion, much less to do the proper downstream analysis. Many of the results are very reassuring because they are in some ways confirmatory for what we suspected, but to have this sort of perspective data before people enter into surveillance is very illuminating, especially for the clinical aspects of our profession. So again, congratulations. I'm going to speak about active surveillance, perhaps from a more clinical aspect, and how her findings can be applied to us as physicians in the context of the search for a true predictive biomarker. I have no financial disclosures to present. All right, well, as Teresa has already mentioned, there are a multitude of active surveillance programs worldwide. The idea that surveillance is not designed to capture or to manage all thyroid cancers, but really to capture the subclinical ones. It began in Japan with Dr. Miyauchi, who's now published on more than 3,000 patients under active surveillance with micropapillary or less than 1 centimeter cancers. And he has shown time and time again that the bottom line takeaway is that delayed surgery outcomes, if they even need it, are equivalent to immediate surgery ones. It has been mimicked by other institutions, including in Tokyo with 230 patients and Sloan Kettering with more than 480. All with slight variations, but further fleshing out the concept of surveillance. In Japan, the Tsuchitani paper concluded that 95% of micropapillary patients can be watched. Memorial Sloan Kettering expanded the criteria to slightly larger tumors at 1.5 centimeters, and also conceptualized the idea of volumetric growth as a metric by which to proceed with surgery. Other indications or other institutions include in South Korea, Cedars, where we are, where we expanded the size cut up to 2 centimeters, and the University of Toronto, which just last week published their institutional series in JAMA surgery with 200 patients. And of course, confirming what we have already known. And then we would be remiss not to mention our colleagues in Italy, as well as other institutions in Colombia and Argentina, really showing how broadly based and generalizable surveillance is. As such, just a week or two ago, the ATA guidelines published their long-awaited guidance on thyroid cancer. And I think this will go a long way to demonstrate that active surveillance, although it will not replace surgery, will take its place alongside it. And really, we have to decide now as clinicians how to place patients in these different buckets, whether it be hemithyroidectomy, surveillance, or total thyroidectomy. I think in one way to demonstrate how difficult it is to place patients into these buckets or these silos is to look at the Memorial paper, which came out a couple of years ago, looking at just how patients change over time. I thought this was an important study because it measured kinetics not just as one snapshot, but over time. Reassuringly, they showed that about 78% of patients were able to be stable. But what we really want to know, and what Teresa's paper is eventually going to try to show us and illuminate, is how do we capture this yellow bucket, the 10% that will have an early increase in tumor volume, the ones that have follow stability and pattern 3 later increase are also perhaps ones we want to capture as well. But it's really these early ones that probably should never have been in active surveillance. How do we identify who those patients are? In that sense, we should probably take a step back and try to describe or define or delineate what a true biomarker is, because in fact, the number of validated examples of what a biomarker are quite rare. In some sense, in the field of biomarkers, there are multiple different kinds. There are prognostic biomarkers, as in, is this likely to develop into this kind of cancer? Diagnostic ones, what type of cancer is it? And the topic of our discussion today, predictive biomarkers. Is this optimal drug or management for our cancer? In many ways, also, I think we want to see a predictive biomarker that has a biologic underpinning, something that's intuitive, exactly what Dr. Ramone has done with her paper. The idea that a biomarker has some sort of understandable underpinning that stratifies patients into proper cohorts. Very easy to understand examples include ER positivity, which selects for ER antagonists in breast cancer, EGFR mutations, which select for EGFR inhibitors in lung cancer. And then in our thyroid cancer world, thyroglobulin is an easy to understand biomarker because it really selects for patients who have recurred and perhaps need radioiodine. So going back to active surveillance, we really think we have to think, well, do we have a good biomarker for active surveillance selection? What have we come up with so far? In many ways, what we have to date is rather crude, right? It's rather imperfect. They're rather not ideal correlates to whether someone's a good fit. In Japan, it started with size less than 1 centimeter. In New York, is it less than 1.5? In LA and in Toronto, is it less than 2? Is it favorable tumor location? Is it older age? Is it slow growth kinetics, as Memorial has described? Is it anxiety, right? Which is another qualitative metric that determines whether someone will stay on surveillance. Or I think the holy grail will be a molecular profile, which Italy has started to explore, as has Hopkins. So let's think about it. Let's put this concept of a biomarker in its strict scientific definition to the test for active surveillance. In 2024, the Korean Society for Thyroid Radiology Imaging looked at whether we could look at location as a stratification or biomarker for surveillance. They created 3 buckets for appropriateness: ideal, appropriate, and inappropriate. Inappropriate being cancers that either are on the trachea or near the nerve, or perhaps at an obtuse angle to the trachea. And perhaps this may be a favorable location to select for active surveillance. On the other hand, we could pick this apart and say that, well, it may be, say, inappropriate, but based on what data? Just based on a gut, based on our intuition, because in many senses, something so small would almost never likely to invade into the trachea or necessarily injure anything in particular. Would a small cancer be threatening or lethal to a nerve? Unlikely, although it has happened. And again, I would say that this is probably an imperfect biomarker for surveillance. Should we look at age? This just came out last week in JAMA Surgery from the University of Toronto with Anna Saka. They looked at 200 patients for active surveillance, and they stratified by age. Someone who is older, greater than 65, was most likely to stay in surveillance, whereas someone who is younger, less than 45 years of age, would have a much higher rate of crossing over to surgery. This again is another perhaps imperfect, but a perhaps effective way to select for surveillance. But crossover in this study was arbitrary: patient preference, size greater than 3 millimeters. Are these really perhaps true ways to predict progression or failure? At Cedars, we've looked at a more qualitative aspect for a biomarker, so-called biomarker for surveillance. We looked at anxiety. We have found that patients who undergo or choose surgery are the ones that have a baseline higher degree of anxiety. These patients tend to stay anxious. So even though they've had surgery, as I show in green here, you can see that their anxiety over years remains persistent. The surgery doesn't cure their anxiety. Meanwhile, surveillance patients who tend to have a lower baseline degree of worry or distress. And even though they're getting lifelong ultrasounds every 6 to 12 months, you can see that they start to become even less worried over time. So is anxiety a correlate for choosing surveillance? Is it a good biomarker? Maybe, maybe not, but it, in a sense, is very qualitative. And so finally, molecular profile, it would seem to me, to me at least, the best fit to be a biomarker for surveillance. Dr. Shing in Johns Hopkins has looked at this for recurrence-free survival, and he finds that although BRAF as a mutation alone or TERT as a mutations alone seems to do slightly worse compared to no mutations, there's a sharp decline in survival in red when you have 2 coexisting mutations. This is widely acknowledged, widely adopted, but for our context, our setting of active surveillance, you might argue that few, if any, microcarcinoma patients truly fit this profile. I've yet to see one in my practice. It might be a case report if one did, and that's because such patients tend to be visible from a mile away. These patients tend to have large cancers, multiple lymph nodes, probably distant metastasis, which explains precisely why they do so poorly. They would almost never really be caught in transit as a microcarcinoma. Dr. Ramone's paper really fits into this area here, but the lack or incidence, as she's described, of correlative mutations remains problematic. It may be too simple of a story to just look for mutations as a biomarker. I'm going to take a further step back and ask, what constitutes so-called failure or progression? In our field, we've looked at 3 millimeter growth. Is it 5? Is it 50% volumetric growth? Is it someone who's developed lymph node metastases? I would ask a further question. Well, are those meaningful, right? Are they plausible? And so, perhaps we should look even more tangibly. Is a failure if someone develops lung metastases? Do they develop cancer-related symptoms like hoarseness? Or, and I'm going to start pivoting to another parallel condition, is it death? In many ways, many of these patients don't have any symptoms. Many of these patients go on with their lives. Should we really constitute or define failure or progression as death from the cancer? I'm going to look at, in a sense, in the last couple of minutes at prostate cancer and how it compares to thyroid cancer, because I think it really sheds some light on what we define to be so-called high risk as a biomarker. Prostate cancer for surveillance uses a number of different parallel metrics. There's PSA, there's core prostate biopsies, there's parametric MRI, there's genomic testing. There are parallels to what thyroid cancer uses. Although they use PSA, we can't really use thyroglobulin because the thyroid is in place. We don't have core prostate biopsies. We have FNA, which as a fine needle is relatively poor at defining high risk. We don't have parametric MRI, but we do have thyroid ultrasound, which is good for defining size and growth. And although prostate has genomic testing, we have molecular testing. But really, in our world, we don't really use molecular testing to determine if someone is a good fit for high risk or low risk. We really look at to define if a nodule is cancer at all. The guidelines have converged on active surveillance. In prostate cancer, they use the Gleason score to define low, intermediate, and high risk. Just last week, the ATA guidelines issued a recommendation 11, which finally offers surveillance as an appropriate management option. Previously, surveillance was nestled within the recommendation for surgery as an afterthought. And so this is showing front and center active surveillance as an area that can converge. Because we're talking about prostate cancer, I wanted to further address why there remains a major gap in adoption. Whereas about half of all prostate cancer patients now undergo active surveillance in the US, and more than 80% of older patients tend to adopt active surveillance, thyroid cancer has lagged. The idea that surveillance for thyroid cancer as a principle has been accepted, but in practice has not really taken off like our other cancer disciplines. Why is this? Well, it could be that prostate cancer patients are older with shorter life expectancy. It could be that prostate surgery is much higher risk. It could be that, and I think this is true, the prostate literature actually has excellent clinical data, 2 randomized clinical trials looking at mortality, ultimately proving that active surveillance works. And that's where I want to really end on mortality. That's really where they define as what is truly failure, not 3 millimeter growth, not development of lymph nodes, but really if patients die. I'm going to spend 2 seconds on this trial, the PIVOT trial, which is a US randomized clinical trial on prostate cancer with 730 patients from the VA. They found overall that observation and surgery were similar. There was no change in difference from death from any cause. And the death from prostate cancer itself, death from the actual cancer was no different whether you had surgery or observation. But I do want to spend 1 second and try to compare this to thyroid cancer, because what I'm really saying is that prostate cancer specific death actually occurred in 11% of patients assigned to active surveillance. This probably would never fly in thyroid cancer, where 11% of our patients signed up for observation will end up dying from the cancer itself. Imagine if this were your grandpa or your father or your uncle, and a urologist assigned them to active surveillance and would say that you have an 11% chance of dying from your actual cancer. Unlikely to be acceptable, but in many ways, the prostate cancer has accepted this as the ultimate endpoint of a good biomarker, whether a patient lives or dies from their cancer. If you read the paper a little more carefully, another 12% of patients develop distant metastasis, which is a major no-no in thyroid cancer. We would probably abandon active surveillance if we had this percentage of patients developing distant metastases or perhaps dying. What I think the conclusion was is that it's unclear if they would have ever done so, or if they would have developed death or distant metastasis, even if they had upfront surgery or radiation. And what I'm really trying to get at is that the thyroid cancer field, so far we've done far better. No one has died from active surveillance on thyroid cancer. So it brings the question, can molecular profiling, no matter how good our techniques that Dr. Ramone has published to date, can we improve upon this 0% rate? All right, so in summary, I wanted to say that the key challenge for us as physicians, and what Dr. Ramone has done an excellent job of doing, is we were trying to parse out the high-risk variants from an otherwise low-risk population. Without a true defined biomarker, it's really hard to define who should undergo surveillance, but without a true definition of failure, it's hard to define what surveillance success looks like. Prostate cancer studies remind us that surveillance has some costs and patient selection is vital. And Dr. Ramone's paper is an excellent step forward in defining meaningful molecular profiles, but it remains elusive. And as I'm trying to say here today, that the bar will remain high. So thank you. I'm happy to take any questions, but again, congratulations on your excellent work. And I'm going to end here.
Thank you, Dr. Ho, for this excellent discussion. And again, I want to thank Dr. Ramone for their work and presentation. I want to address one of the questions from the audience and go right ahead into it. The question is, have you looked at microRNAs profiling in these micro PTCs versus macro, I'm guessing greater volume nodules, with BRAF V600E mutations that have a more aggressive profile?
Thank you for your question. No, we did not the comparison of RNA expression profile between these two group of PTC, macro and micro PTC. We performed only the genetic analysis for a single nucleotide variant, and for how to concern RNA, we studied also the gene fusion. We compare the genetic molecular profile between low risk papillary thyroid cancer under active surveillance with a group of papillary thyroid cancer that showed lymph node metastasis at the diagnosis, but we didn't find any difference between mutation found in these two groups of cancers of patients. And surely this is one of the limitations of the study, is the study only of the molecular genetic markers without gene expression profile. We can perform it in the future. Also, the material that we have obtained from fine needle aspiration is probably too low also to perform expression profile in this group, but we will try it.
Thank you. Dr. Ho, do you have any follow-up to that question? Do you have any information about microRNA profiling in these scenarios, micro versus macro PTC that are BRAF mutated?
I'm sorry, I lost you for a second. Were you asking me?
Yeah.
Okay. No, I don't. I find that it's very difficult, especially if you look at TCGA and subsequent work. You really don't find signals until you start looking at much more aggressive cancers, the poorly differentiated, the anaplastics. Even they are, relative to other cancers, tend to be a little bit more quiet when you look at those oncoprints. I had a question for Teresa. You know, it is there are a multitude of papers and a multitude of investigators who strongly believe in BRAF. They they look at they in their institution, they stain for it in every thyroid cancer case, and they feel like there's a signal where BRAF predicts for more aggression. You clearly have shown that more than 60% of your cases have BRAF, but you seem to have come to the opposite conclusion. How do you reconcile the papers out there that show aggression with your data that shows that perhaps it's not as terrible as we might suspect?
Thank you for your question. Yes, the role of BRAF remains controversial in the literature. I think that the low-risk papillary thyroid cancer under active surveillance, they are selected patients. Probably in these cases, this is a different type of behavior, biological. They have a different behavior, biological behavior. This type of cancer. BRAF V600E causes the tumoral transformation, but probably not the progression. I think that in these cases, it's very important to look secondary mutation as TP53 alterations, TERT promoter mutations, or other molecular or other single nucleotide variant that we have not identified. It could be of interest to analyze these patients also with with NGS panel that include more genes that respect that the panel that we have used, for example, also whole exome sequencing, and then to repeat the analysis also after more years that they are in active surveillance to detect additionally mutation, for example, after 5 years of active surveillance or 10 years of active surveillance, if the patients are stable or in progression, to detect the difference.
Sounds like it's not just a single hit, but it's multiple hits that drive whether something becomes more aggressive, right?
Yes, also copy number variation, for example, they could have a role in tumoral progression. The chromosomes, the alteration on the chromosomes, chromotripsis, or other genetic events that are recognized, for example, for other cancers to contribute to the progression.
So this is very interesting. The guidelines so far, they have given us a couple of moments in the follow-up of patient with a thyroid nodule or thyroid cancer where we should do molecular diagnosis. And for example, in the case of a patient with an a cytology intermediate thyroid nodule, where you do molecular diagnosis, if you get a BRAF mutation, let's say that we have a patient with a 1.3 centimeter nodule that is called Bethesda 4, and you get a BRAF mutation, you take them to surgery. However, if they were put in active surveillance, the current data doesn't seem to push to get the patient out of active surveillance. Am I getting it correct? I do want to land on what Dr. Ho was asking. How do we reconcile this information? It does seem like there is no characteristic in thyroid cancer being from ultrasound to cytology, pathology, and now molecular diagnosis that as a standalone can predict prognosis, but it seems to be I don't know, like the constellation of those characteristics that make a driver to change the prognosis of a thyroid tumor. Is that correct? What do you think of that discrepancy, Dr. Ho, where you find a mutation and you would take a patient to surgery, but it seems that that doesn't change how we surveil patients if they are fit for active surveillance?
I think it's a simple matter of prognosis versus diagnosis. I think BRAF is excellent at a diagnostic maneuver. It's poor at a prognostic maneuver. So you can't really use it, in my opinion. I think there are papers, and they've tried to splice it different ways. I think the Hopkins group has mentioned that BRAF plus old age tends to be prognostic. But you're right. I think for now, what the field has settled on is using particular mutations in particular BRAF simply for diagnosis. And that's what we use. We don't really exclude patients from active surveillance if they have a BRAF mutation. In a sense, it provides more clarity, right? From an indeterminate nodule that, is it a maybe, it's a gray area. Now it's clearly cancer. We should just treat it as, we should just view it as such. But we don't necessarily send them to surgery. Though you're right, most of the world probably would.
Correct. I want to thank Dr. Alice, who has given us a comment. She sent a comment, and I'm going to go ahead and read it. She says, this is a comment more than a question. I'm sorry. Do we agree that small papillary carcinomas that do not have lymph node metastases at diagnosis are slow-growing carcinomas? If so, since active surveillance is an option, in all cases with small papillary carcinomas, we can avoid performing surgery immediately but postpone it until growth is evident. And is this without any risk? Then there will be cases that progress earlier in young patients, for example, but they will still have gained a few months, years of normal thyroid function and freedom of medication. What do you think about this, Dr. Ho? So should we let the weeds in the gardens grow if weeds don't see any progression, and avoid patients for early start on medication and potentially risks from surgery?
It's a very difficult question, and conceptually, I completely agree with the commentator. As I mentioned, it's hard for clinicians to stand firm and stand by this particular comment because we don't have the randomized clinical trials that the prostate community has. Once we have them, rather than say prospective observational studies or retrospective studies, then we can much more easily define a foundation by which to follow what this commentator is trying to say. We also have to look at the costs, not necessarily financial costs, at least not in the US, but the psychological or emotional cost, and also what does the surgery cost the patient? Because the surgery is, knock on wood, tends to be fairly straightforward in most cases, not all cases. As an outpatient surgery, a relatively small incision, so on and so forth. Many patients consider it to be acceptable, right? To just undergo surgery and have a definitive solution rather than, as you mentioned, let the weeds grow. I like that expression because they would prefer to have that peace of mind. So in many ways, this is a complex question, but without the high level evidence that we need to make a stand.
Thank you. I'm gonna go back to the original study for just a second. There's a couple of persons asking about the results, and if you think the conclusion is underpowered by the only the 8 cases that progressed, do you think if we had a larger cohort, a larger number of cases, would this statistical analysis and result would have changed? Dr. Ramone.
Thank you for this question. I don't know. I don't think that with a bigger number of progression patients, the result could change. Also because we have a prevalence of BRAF V600E mutation in 66% of cases. So if BRAF V600E is correlated with progression, I will expect to have a big number of patients in progression. But after 10 years of follow-up of these patients, only a low number of BRAF positive cases, only 5 patients showed the progression. In the waterfall graph, I showed you that the patients BRAF positive were in active surveillance after 10 years of follow-up without any evidence of progression. So I don't think that is a problem of statistical analysis. I think that is a particular type of low risk mPTC without the features of progression similar to other type of cancers.
Correct. And from those 8 patients that did progress and you sent to surgery, do you have any pathologic characteristics that correlate to the progression? Is there any outstanding characteristic in the pathology of these patients, or in, I don't know, I didn't see a mention of the initial location within the thyroid parenchyma where they were found. Going back to the Japanese studies that specify which patients are ideal or not ideal for active surveillance. Do you have any correlations of what happened to those 8 that did progress?
We don't look these features. We know that all 8 patients showed the diagnosis of PTC. the 7 of them was a classical histology, and one of these patients had a solid histological variant. We did not correlate the position of the tumor in the gland and other characteristics. We know that they are all cured until now after the follow-up period in clinical practice. But this is a good suggestion for the analysis. Thank you, Camillo.
No, of course. I want to thank both of you. I wish I could stay here for another hour discussing this, but we're just about to hit the 9 o'clock hour. And I want to thank both of you for carving out some time and really early in the morning and really late in a Friday evening. Thank you both for being here and for sharing this presentation and thoughts with us. I want to invite you to come back to the next presentations in the TIRO by MDs next week. We don't have one
It's
since
7
we
hours.
will be attending the ATA. I really hope to see some familiar faces while at the ATA. I want to wish you a great weekend and stay safe.